All right, so welcome everyone to tonight's session. I'm going to share my screen and get to my presentation slides. You should see now my lead slide, which says the truth about shoulder pain. And that's what we're going to talk about tonight. So just as I was saying, if you want to interact at any point tonight, click that chat button. I've got it enabled now, so you should be able to communicate with me that way. It shows me a little signal that you've got a question there, and I'll try to get to that, and I'll let you contact me too. I took the poll questions out tonight. There are not any poll questions, so you can't interact that way, but the chat feature is a great way to do that. I appreciate you spending some of your precious time with me tonight. Why in the world would you want to listen to me? Well, I'll start very briefly by saying I've been around for a while and I've learned a ton through the School of Hard Knocks and lots of experience. I'm a University of Iowa physical therapy graduate. This is the first time I can say I'm proud of my son, who is a fifth-year senior. He just got accepted into the same program that I'm a part of. He's just going to start 29 years later than when I started. University of Iowa is a great program. Happy to have gone there, and really was an effective way to learn. Got some advanced learning through a group called Evidence in Motion, where I got my Doctor of Physical Therapy degree about 10 years ago. So that gives me 26 years of experience as a physical therapist, working with lots of different people with musculoskeletal issues. What you're going to learn tonight are things that I've learned through that experience and through my training. The training was really good, but it's not until you see a lot of people complaining of the same thing and walk them through that process that you start to see trends developing. And early on, as a young physical therapist, some people started to feel better. I think in many cases, despite me. I've got a lot better at understanding the mechanical nature of these issues, that people will get better and not end up returning to me. I had it many times where people came back after a few months and said, "Boy, you helped me last time. I really want you to help me again." And I said, "Thanks," but there was a part of me saying, "Boy, did I really help them then?" And I think I did, but as I've learned through the years, the key to success is not just making it feel better, but to make sure it's functioning better. And that enables you to not just feel better for a short period of time, but to do what you want to be able to do without exacerbating the shoulder condition over the long term. And so we're going to talk about that. The physical therapy practice that I represent is called Kinetic Edge Physical Therapy. We are celebrating our 25th year of operation this year. We have 8 clinics in central and south central Iowa. Just added our 8th. I'm in Albia right now, our new clinic. And we're excited to be serving that community as well. Low back pain is the #1 reason that people come to see us. And that's not surprising because that's a really common issue. Shoulder problems are the #2 reasons that people come and see us. And I think I did a little math 6 months ago or so. And I think in the last 3 years, we've done something like 30,000 sessions with people with shoulder issues within our practice. Now, it's certainly not just me. I'm one of 40-some physical therapy providers within the practice. And together we teach and learn from each other, which is really neat. One of the approaches that we take, and you'll learn a little bit about this tonight, is the 3D MAPS approach. Your shoulder doesn't exist in a vacuum. That's one of the truths that we're going to talk about tonight. It exists as a part of a dynamic system, and it is impacted by everything around it. In fact, we're going to learn tonight, we're going to talk a little bit tonight about how as people, we influence, for better or worse, those who are closest to us. And those who are closest to us are most likely to influence us. How we think, the way we see the world, that kind of stuff. Well, in your body, the same is true. Tonight, we're going to talk about what influences your shoulder. And so I'm letting the cat out of the bag a little bit. There's lots of things we can do: ice, ultrasound, electrical stimulation, manual treatments to make the shoulder feel better. And that's important. Don't get me wrong. But that symptom, the pain, is a symptom of a deeper issue. And you have to look beyond the shoulder itself to the closest neighbors that are most likely to influence the shoulder. If you want to take away the stress that's causing the shoulder to raise its hand and say, "I need some help," to begin with. That's where we're going to go tonight. Now, some of you might be thinking, is this really for me? So let me tell you who this workshop's for. First of all, most of the people who come to see me complaining of shoulder issues didn't just have a pain and come see me the next day. They dealt with it for a while. They thought it was getting better, but it got worse, most of them. And over time, it tends to get worse. And as a result, they learned there are probably some things I shouldn't be doing. and they avoid doing things. Sometimes they avoid doing things they really love. Younger people, for example, who play baseball, if they have a shoulder issue, might have to give up throwing, at least for a period of time. Older people or middle-aged people who want to do home projects know that they can't do overhead painting because their shoulder bothers them. Now, older people just have a hard time putting clothes on at times and doing daily function tasks around the home because their shoulder bothers them. In a nutshell, as it becomes a bigger problem, it's less likely we're going to do what we want to do and more likely that we're going to be dependent upon others to help us. And so if you're thinking, I don't want to become dependent upon others, I want to be able to do for myself as long as possible, this is a great workshop for you to be attending. Many people that deal with shoulder issues have a hard time sleeping at night. They have minor to moderate pain during the day, but they can do stuff and get it off their mind, and it doesn't cause them that big of a problem. They lay down at night, their brain stops, their body stops working, and that pain gets worse at night. If you have nighttime shoulder pain, first of all, there's a reason for that. We're going to talk a little bit about that. Nighttime is supposed to be rest time, recovery time, healing time. And if you're not sleeping well, your shoulder is not going to be experiencing that. Your entire body is not as well. Because we influence those closest to us for better or worse, when we are more consistently in pain, having shoulder pain, it's hard to be in a better mood. And when we're not in a good mood, it's difficult to have a positive influence in those around us. So if you want to be in a better mood so you can be more positive to those who depend upon you, I'm glad you're here tonight if that describes you, because this should help you take better care of yourself and your family. Some people just want to avoid at all costs high-risk procedures. Now, what do I mean by that? Any kind of a shoulder surgery, any surgery whatsoever, there is a degree of risk there that if we can avoid, it's a good idea. And so any procedure that you might open yourself up to a risk is something worth avoiding if at all possible. You can't undo a surgical procedure. So if we can find ways to avoid that, push it off as far as possible so you can function naturally, this is the place for you to be. Some people have gotten to the point where they just have to manage it with medications, their musculoskeletal pain, and there are negative side effects over time from doing this less natural version. Now, medications have a role, and at times they are absolutely necessary, but long-term, we don't want to be using medications to manage shoulder pain. So I'm going to give you options on how to reduce the likelihood you have to continue to take medication and therefore are less likely to experience those negative side effects. Most people here just want to move better and feel better. Okay, so I'll tell you this, I wish I could snap my fingers and make all your pain go away. I'd be a pretty popular guy if I could do that. I can't, but I can tell you this. If we find ways to take the stress off the tissue that's giving you the warning sign, you are going to feel better. Your pain will be less frequent, it'll be less intense. Any episode will be of a shorter duration. And I can promise you that if we can find ways to take pressure off the tissue, take stress off the tissue, that is effective at helping you feel better. Absolutely pain-free all the time? Maybe not, but moving much better, more comfortably and more functionally, that is definitely an achievable goal, and this workshop's for you. Now, if you were coming here tonight thinking he's going to teach me this special exercise, if I just do this one exercise, all my shoulder problems are going to be solved. Again, I wish I could do that, but there really is no such thing as a quick fix in almost every case. Now, you go online and you're going to think there's lots of people promising big results that would like to take a little bit or more of your money to do so. Most of those things, if they give you any benefit, are not long-term benefits because they do not get to the root of the problem. We're not looking for ways to temporarily reduce a symptom. Tonight, we're looking for ways to get to the root of the problem. And so if you were hoping for the quick fix, I'm not going to provide that tonight, and you are welcome to leave if you want to, but I hope not, because what we're going to do tonight is going to allow you to move better so you feel better, which in general is really good for you. It's going to allow you to take control of your shoulder, but also take control of your overall health as well. Now, there are some times where shoulder surgeries are necessary. Maybe some of you who are with us tonight have already had a shoulder surgery. I can tell you I've seen a ton of people who come to therapy already having had shoulder surgery several years ago, and unfortunately, they are still dealing with similar problems. You can get rid of the impact of damage at any joint, and you can get some temporary benefit from that. But this issue is likely not just a complex structural issue at the shoulder. It's more likely a mechanical movement-based problem. And you can reduce the structural damage without fixing the root movement problem and still have pain. And so I'm trying to give you ways to deal with this issue much more naturally. Now, it is interaction time. I want you to answer a simple question for me, and I really want you to answer it. If you want to click on that chat button, that would be great. Just tell me, is there a specific activity, a motion, a position, whatever? If I do this, I know my shoulder is going to hurt. Can you predict that to some degree? That with your experience, I know I have to avoid certain things, otherwise I'm going to experience more pain. Tell me what that is, if you would. This is a really important question because your answer to that question will tell me whether or not what I'm going to tell you tonight is likely to be beneficial for you. Now, if you want to, you can answer the next two questions as well. How bad does your pain get on the 1 to 10 scale, with 10 being the absolute worst emergency room kind of pain? And then how long have you been dealing with this? And you don't have to be specific. You can say days, weeks, months, or years. Let me know what you got on that. So anyone going to be, there we go. We got them coming through. That's really good. So Michael says low to mid-grade pain, long-term, no single movement, and it's been 6 or 7 years. So there you go. Okay, wonderful. So is your pain consistently a 6 or 7, Michael, or does it come and go a little bit? That's my next question. Anyone else have any specific movements, actions, positions, activities that they avoid because of this? Michael says it does come and go and it can disturb your sleep. Okay. Steven says the butterfly machine at the gym. Okay, so that's using the pec muscles 3 or 4 in about 8 months. Okay, good. Diana says sleep and repetitive movements. There you go. So those are 2 of the things we've already talked about a little bit tonight. Stephen, when you talk about 3 to 4 pain and about 8 months, I'm going to tell you this. Those are good answers for this. And the reason I asked those questions about how high the pain gets on the 0 to 10 scale and how long you've had it is not that that's going to determine whether or not what we're going to talk about is beneficial for you. But if your pain is higher and it's been around for a longer period of time, the process to resolve it, to eliminate it, to reduce it, does tend to take a little bit longer. That tissue got worse over time. It's a process that brought it to that point, and it's probably a longer process if it hurts worse. And probably going to take some time to overcome that too. Karen says macrame. There you go. I haven't heard about that in a while. That's the exacerbating task. So that's a specific action, motion, up to an 8 in about 2 years. So again, that's a higher pain for a longer period of time, Karen. Now you can still help that, but that tends to take just a little bit longer. Good, nice job. I appreciate your feedback, folks. Here's why I asked the question. It kind of sounds weird, but if you tell me that your pain is reproducible with a specific activity, and these are the 3 things I hear easily the most: reaching, lifting, and laying down. Specifically, if I lay down on the involved shoulder, but not even necessarily with that. So if you have a specific activity that says, if I do that, it's going to get worse, that means your pain is reproducible. But if your pain is reproducible, it's actually kind of good news, because if it's reproducible, it's also reducible. Okay, so if your pain is reproducible, it's probably reducible. The reason I say that is because if there's something that makes it worse, that means there's a mechanical issue. Okay, we think of this as being a medical problem, but I think we need to first think mechanical. So what do I think about mechanical? Well, I'll use an analogy. Okay, pretend you're driving down the road. It's a perfect spring day, 72 degrees, sunny out. You got your favorite car, maybe the top down on that car, listen to your favorite band on the radio, and suddenly this light comes on in the dashboard, right? Well, if you're like me and most people, you're going to say, oh, that darn light, I don't see anything, I don't hear anything, I don't smell anything. That thing is not to be trusted. And so we keep going. I know I've done that before. But imagine, if you would, that if you keep going and a few miles down the road, not only does that light stay on, but now you start to feel a little rattle in the engine compartment. And maybe you start to smell a little hot smell, maybe a little smoke starts to come from underneath that hood. these are more significant signs and symptoms that something's going on in the car. So right away then, if you're like most, you would probably pull off and say, oh, okay, maybe I should have paid attention to that light on the dashboard. But what if you did this? What if you popped the hood and also popped your trunk? And when you got out of the car, you went to the back of the car first, because you knew in the trunk you had this big, thick blanket. And you grab this blanket and you walk around to the front of the car and you throw this big old muffler, essentially, on top of the engine, and then you slam that hood down, right? So now I can't hear the problem. I've muffled it, right? The smell's not going to get through. That's all good. And then you go into your car, because in your glove box, you've got this duct tape, and you're going to take a piece of duct tape and you're going to put it over that light on the dashboard. Have you fixed the problem? Okay. No, you haven't fixed the problem. You've gotten rid of the signs and symptoms of that problem. But if you get in that car and take off, the mechanical issue still exists. So if you have a reproducible symptom and you choose to eliminate that pain by taking some medications, an injection, that kind of a thing, that might make it temporarily feel good because you've muffled it, but you haven't gotten to the root of the problem. It is smartest to fix the mechanical issue that is the root of the problem. What we're talking about here is different types of trauma. And I'm going to talk specifically about two types of trauma, acute versus cumulative. You can see that on the screen right there. And let's graph it out. Acute trauma and cumulative trauma are very different. Acute trauma comes on suddenly, and then because we are humans, organic beings, we're made and created to heal over time. If we take away the irritating factor, the body will find a way to get better in most cases. So this is what it looks like. Sudden tissue damage, there's an immediate cause and effect noted with that. So let's say you give someone a high five and they snap your shoulder back and your shoulder dislocates. That's acute trauma. That one thing caused it, right? And there was sudden tissue damage and symptoms along with that because it immediately went above the symptom threshold. Now, given time, over time, the body goes through a healing process. And in most cases, even people who dislocate their shoulder are going to get better over time to the point where it hurts less and maybe even gets below the symptom threshold. That's acute trauma. That happens to shoulders. People come see us in the clinic after they have something like that happens with their shoulder. And that is a reality. However, cumulative issues are much more common. I wish I had a dime over the last 26 plus years when someone said to me, I don't know what I'm doing different. I'm doing the same things I used to do, but I hurt now, okay? Well, we've got things that are happening gradually to the tissues of the shoulder that eventually allow it to get above the symptom threshold. So it looks like this, little changes occurring, and you don't even feel it until you cross the symptom threshold, and then you start to feel it. Now, if you're just above the symptom threshold, you're going to say, well, the pain's not bad. You know, I can feel it. Something doesn't feel quite right, but it's not too bad. And we just keep doing things. But if we continue to expose the shoulder to the same mechanical stresses over time, the symptoms do tend to get worse. So the analogy I talk about is this bucket analogy. This is what cumulative trauma looks like. It's kind of insidious, slow, and gradual, but it's oftentimes very predictable. Okay, so think about a bucket taking on some water. Okay, a little bit of water in the bottom of the bucket. The first thing we notice with cumulative trauma is fatigue. Okay, I've been a physical therapist half my life, and I can tell you it's not the most physically demanding work, but I don't have as much energy at the end of the day and at the end of the week as I did when I was a 25-year-old new physical therapist, right? So bodies don't last forever. Fatigue's normal. That's a reality. Most people can just kind of say, okay, I get it. I'm not that young. And we kind of ignore that, right? So more water fills the bucket because we continue to do the same things. And as more water builds, we get to that next level of cumulative trauma, discomfort. So discomfort is something doesn't feel quite right. It's maybe a little stiff, slight soreness. The intensity of the symptom is not as significant when it's discomfort. And again, it's oftentimes because we don't like to be squeaky wheels or admit our humanness. We ignore discomfort in many cases and just kind of think of something different, do something to avoid dealing with the primary problem, more water fills that bucket, and eventually discomfort in many cases gives way to a more significant symptom. Pain is different than discomfort. It's more intense. It's there more often. It's a bigger deal. And we're almost having this little overflow, right? When you have an overflow, we're dealing with a bigger mess. That's when that tissue damage is more significant. So here's the deal. When you get pain, pain is serving a purpose. It's telling you that your tissues are experiencing some problems, some discomfort. It's the light on your dashboard. But mechanically, there hasn't been enough going on there that you're getting big problems, right? But if you allow that go long enough, eventually the warning signal, if you don't heed it, leads to a mechanical outcome that's not necessarily good. So my goal is to make you aware of this and do things where we can move you back to the left side of this graph here. More fatigue, less discomfort, less pain, less tissue injury, okay? But this is really the path. The path is defined by symptom frequency, intensity, and duration. The farther along we travel on that cumulative trauma path, the more frequent, the more intense, and the longer duration these symptoms are. And unfortunately, what that means is that we move less. We don't do the things that hurt, so we do less. And ultimately, that can lead to worse general health. Now, that can happen to some degree with shoulder issues. It's much more likely to happen if it's your low back or your knee, weight-bearing joints that are harder to give relative rest to. But the reality is less movement's not good for us, and it has a large consequence on more than just our musculoskeletal health. It affects our general health as well. There are 6 things that Americans spend about, I think it's 86% of their healthcare dollars on. 5 of them are impacted by the movement quality and quantity. Number 1 is musculoskeletal issues. A shoulder issue is a musculoskeletal issue. That is easily the most significant healthcare cost in America today, and it's positively influenced by quality and quantity of movement. Number 2 is heart disease. That is the number 2 cost. It's also positively influenced by quality and quantity of movement. Number 3 is cancer. There are some cancers that could be positively influenced by that, but it's not primarily a movement issue. The next 3, which are 4, 5, and 6 on the list, diabetes, obesity, and depression, all of which are positively influenced by the quality and quantity of movement. We need to keep moving. We need to move as well and as often as possible. And that's what my goal is here, is to help you do things better so you can do the things you want to do. And overall, you can just be healthier because you move more and you move better, which should lead to fewer doctor visits, less medications, fewer surgeries, all good things. Now, I've alluded to this already. The way people typically respond to problems is not productive, but it is kind of human nature, right? If the issue doesn't seem too big, we want to ignore it. Most people don't want to be squeaky wheels, not that big of a deal. I'll just keep going, right? But you know what the definition of insanity is, right? You do the same thing and expect a different outcome. That's not what happens. In most cases, these mechanical musculoskeletal issues result in gradual worsening of the pain. The frequency, intensity, and duration worsens, and eventually you can't ignore it anymore. And if you're here tonight, you're not ignoring it because you've raised your hand and said, I want to hear what this guy has to say about shoulders. Unfortunately, most of the things that we do initially are simply ways to alter the pain. And even physical therapy to some degree does some of this, right? I said it earlier, ultrasound, electrical stimulation, those don't solve problems, they just manage pain. Now, don't hear what I'm not saying. It is okay to manage pain. We want you to feel better, right? And it's okay to do those things, but it should not be the end product of a successful strategy to overcome your shoulder pain. That's because altering the pain through medications, injections, surgeries, and other treatments doesn't get to the root of the problem. So my challenge to you tonight is we want to solve the problem. And that is, once again, looking at how that shoulder operates in a dynamic system of movement, how it's being influenced by its closest neighbors. We need to find and fix the root problem. We need to take it out by the root. And that's what we're going to talk about tonight. So the key point you need to understand is this. Despite the way we're taught to think, this is not a medical issue. Your shoulder pain is not a medical issue. It is a mechanical issue. If it were a medical issue, it would benefit from medicinal treatments, right? Chemistry treatments. If you lifted up your sleeve and looked at your shoulder, there's no dial on there that says, you know what, I'm low on ibuprofen. I better take more ibuprofen. That's going to make it better. Again, that masks the problem. You cannot treat a biomechanical issue successfully with a biochemistry treatment. These are movement-based issues that need movement-based solutions from people who understand proper and effective movement. That's the key point. It's not a medical issue, it's a mechanical issue. Very, very briefly, I want you to understand this, and this is poking and prodding a little bit about how we naturally deal with problems once we realize we can't ignore it anymore. The thing that most commonly happens, sorry, I just dropped something. The thing that most commonly happens is people will ignore it for a while until they can't anymore. They'll go online and they'll see what they can do about it. That's happening more and more all the time. Some of you will go to your doctor, and I've got many friends that are doctors, and they tell me, I don't know what to do with these people. And here's the deal. Musculoskeletal issues are the second most common reason people go see their doctor, behind respiratory issues, right? Especially in the last 3 years, right? But doctors almost to a T do not get any musculoskeletal training. They tell me, we don't know what to do. So we're going to give them a medication to help them feel better because that's what they want, right? And if that medication doesn't help, we'll probably do a diagnostic test. And when we do a diagnostic test, we're probably going to find something's wrong in there, which means we better send them to a specialist. And they might end up having injections or surgery or something like that. All too often, they don't get to us. Now, here's what I want you to understand. To hurt because you have inflammation is a normal thing. When tissues get damaged to some degree, and that damage is oftentimes, at least in part, a mechanical issue, they go through a natural process that has 4 phases. Inflammation is phase 2. That's a normal part of the healing process. During inflammation, the tissue is sensitive, right? It's sensitive because the body needs to tell the brain, don't do things that are going to hurt this thing. Let's get through this process. The inflammation process is when the body starts to develop the initial framework for the development of new blood vessels in that area. And those new blood vessels are absolutely essential, because if you can grow those blood vessels to proliferate and mature, you're going to have a means by which to distribute the organic nutrients that your shoulder, your injured tissue needs. If you pop an anti-inflammatory, and that's really common, right? If it hurts, I'm going to take an anti-inflammatory. I'll take ibuprofen or another non-steroidal anti-inflammatory drug. That actually stops the inflammation process, right? And so it prevents us from going through the proliferation and maturation phases. We don't get this development of the blood vessel growth. And so it's kind of a trade-off, right? I feel better temporarily, but I really have not allowed the body to go through that healing process. So I would lie to you if I said I'd never use ibuprofen or never encourage a person to use ibuprofen. It happens from time to time, but I'm much more interested in helping them move in ways that doesn't cause pain or doesn't irritate the pain, and gradually increase their movement tolerance so that we can go through the inflammation process and allow those vasculature, all that vasculature to grow and develop the way it needs to. Now, you might be thinking, well, I'm not a spring chicken anymore, right? Well, I want to tell you a story before we get into the nuts and bolts about John. I saw John over 20 years ago, and at the time he was 92 years old. This is not a picture of John, but I found it online, and it looks very much like John. John was an old man, and he came to me with shoulder pain, and he said, boy, I went to the doctor, and they did a test, and they found out I got a major tear, massive rotator cuff tear, okay? He's like, I can't even hardly work to get the hand to the top of my head. He said, I don't want to go through surgery. My heart's not strong enough for that. The doctor didn't want to do that. I'm going to give John a lot of credit. Many people in John's state would have been depressed and anxious about it, right? That's natural. This is really negatively impacting my life. And he's like, I'm going to do something about it. I'm going to get better. And so he came to me. I was a young therapist. And I'm like, okay, John, well, we'll see. You got a massive tear. Let's see what we can do here. But what we did is we assessed him, and I was honest with him. I said, I can't make that rotator cuff tear go away. But I said, we can work on a lot of stuff around that shoulder, and we'll see. We'll see how you can develop your movement patterns. Hopefully you can move better and experience less pain. But you're old, and this is a major tear, and it's going to take some time. So he said, let's do it. And so he had lots of mobility restrictions. It really negatively impacted the mechanical capabilities of his shoulder. We worked on overcoming a lot of these deficits, and after about 8 weeks, the end result was he was getting his arm overhead all the way to the top of the kitchen cupboard. As long as he took one cup or one plate down at a time, he was fine. He couldn't take a whole stack, but he's like, I don't hurt like I used to. I can get about 18 inches higher than I used to with my reach. I'm perfect. This is great. So I'm telling you, if John can do it, you can do it too. You have much more advantages over a 92-year-old John from over 20 years ago. All right, so let's talk about your shoulder pain types. First of all, look at this shoulder, okay? The shoulder has the upper arm bone, the shoulder blade, of which as it comes around, you have this little bone called the acromion. There's a ligament that bridges the gap between these two bones on your shoulder blade. And through that tunnel made by that ligament, there's one of your 4 rotator cuff muscles called the supraspinatus. You got a bursa in there. Part of your shoulder also is your collarbone and your sternum. That is your chest bone there too. Some people, this bone has a funny shape. It's supposed to be flat. Some of them angle a little bit more, so that tunnel gets a little bit more pressure. It's more prone to impingement related issues. Now your shoulder, like every other body part, is made to move 3-dimensionally, and it does too. Flex and extend, abduction, adduction, internal, external rotation. Every body part moves 3-dimensionally. There are 4 bones. There are 4 joints that make up your shoulder, actually. The joint from the sternum to the collarbone, collarbone to shoulder, and then the shoulder blade itself and the joint as it connects to the spine there. So there's lots of stuff happening there. In fact, there are 21 muscles that connect to your shoulder blade, believe it or not. So a really, really complex structure for all of this anatomy to work right together. And to do that well, like I said earlier, your shoulder does not exist in a vacuum. It's influenced by what's happening down and through the kinetic dynamic system of movement, okay? Now, when we talk about these types of shoulder pain, I'm not really giving you a description of the cause. I'm just kind of giving you a description of what's happening. It's kind of a diagnosis that we're talking about. So we're going to talk about arthritis, we're going to talk about impingement, and we're going to talk about rotator cuff related issues. Let's start with osteoarthritis. If you break that word down, arth is joint, itis is inflammation, osteo is bone. So it's inflammation of the bone and the joints that those bones make, right? It's an inflammatory process. It's an itis. And any of those 4 joints I just told you about could be experiencing a loss of cartilage. In fact, it's really, really common. If you're 40 years of age or older, and even if you don't have shoulder pain, 89% of those people have evidence of arthritis when they do an MRI. So arthritis is as normal as wrinkles on the skin. It happens to everyone. And here's something you need to know. Cartilage itself doesn't have any nerves, okay? As a result, nerves are the things that allow us to sense things, including pain. So damage to cartilage itself is not painful because those cartilage fibers don't have nerves. Now, it's evidence that there's mechanical forces at play there that can impact other things in the joint that are painful, but the cartilage itself does not have or experience pain. Osteoarthritis is primarily, there are other factors at play, but it's primarily a wear and tear problem, okay? And so it's real normal for people to experience that, but if it's really advanced, it's evidence that there's been more mechanical issues over time. But even if you already have advanced arthritis, taking stress off the arthritic joint by helping all the parts do what they're designed to do is a way to unload, unstress the tissues. And when you take stress off of tissues, they feel better. They will give you fewer symptoms and you can function again. Now, impingement is closely related to arthritic changes. Here's the ball and socket joint, the shoulder blade and the upper arm bone. You can see that it's made when we raise our arms for that ball to rotate on the socket. It's like a golf ball sitting on a tee. And the responsibility of these 4 rotator cuff muscles is to guide the ball on that socket in a complex movement as we move in many different directions through 3 dimensions and combinations of those motions. Now, in some cases, the pull of the rotator cuff is such that it doesn't rotate the joint, but it kind of lifts that bone up into the joint. putting pressure on the very tissues that travel through that tunnel. And you get enough pressure, and that's problematic. Now, these joints are made to absorb forces. Pressure is normal. The problems exist when the degree of pressure, which could take a lot of time, exceeds the demand capabilities, the design capabilities of that particular joint. So if we can get the rotator cuff to do its job well, we can teach it again how to rotate the ball on the socket instead of it just kind of pulling up and yanking into that subacromial space and causing impingement of those tissues. And remember, it's not just the tendon itself, it's this little fluid-filled sac. So some of you may have been told that you have shoulder tendonitis or bursitis. They're often kind of one and the same because they're going to get pressured in that subacromial space by the same mechanical issues. Okay, now here's the deal. More pressure because of poor mechanics of the ball in the socket leads to friction, and friction is what brings about the inflammation. Now remember, inflammation is a natural part of the healing process, and it stimulates the body to start to develop vasculature to feed those tissues. And here's what I didn't say earlier, those white tissues do not get good blood flow under normal circumstances. So we need that inflammatory process to do its work to supply that area with blood and nutrients as well as possible. Especially during the early to moderate stages of impingement, we won't even see this on diagnostic tests. It will look pretty normal, but it is very treatable by looking at how the mechanical function of the shoulder is operating. And research would show that surgeries done to reduce impingement of the shoulder are not very effective because you're just getting rid of the impact of the mechanical issue, not fixing the mechanical issue in and of itself. And if you have nighttime shoulder pain, it is probably at some level of impingement. There's some tissues, either and or the tendon or the bursa that's pretty inflamed. The deal with the nighttime shoulder pain, the space between the top of your roof of the shoulder and the ball that's in there is only about 5 millimeters. And when we lay down, it takes about 2 millimeters. And if that tissue starts to inflame at the night, when we stop moving, which is really common, you've got less space and more stuff taking up space. That's why nighttime shoulder pain is so very common. Now, testing for this, especially if there's an active impingement going on, is really easy. If you turn the thumb down and lift the arm up, that creates a pinching of the ball in that socket. And if that's irritable, you can even do that to yourself. Straighten your arm out, turn the thumb down and raise it up. And if you can feel direct pinching in that area, that's a sign that you likely have impingement in that subacromial space right there. Okay? And again, I'll say this once more. The shoulder's made to take on stress, right? The elimination of forces is not possible, nor is it necessary. We just need to minimize the amount of stress so it doesn't exceed the design threshold of that tissue. And helping it move better accomplishes that. All right, the third most common type is rotator cuff strain issues. Now, what we're seeing here is on the left, the start of some inflammation on that rotator cuff, right? And oftentimes over time with cumulative trauma, where the tissue continues to experience more stress and breaks down more and more, that can eventually lead to some tearing in that area. And this is a massive tear. Most of the time, the tears are really small tears. And here's another interesting note. Many people that have rotator cuff issues actually do have some small tears. You don't need to fix those small tears in most cases. You just need to teach that joint how to move mechanically better again. Even people that have rotator cuff surgery to fix tears, most of them that have good outcomes from that still have some degree of tearing left in the shoulder too. That's what the research would show. So elimination of tear isn't necessarily necessary either. It can still get better by teaching those things how to move. Now, the more massive the tear, the more significant the mechanical compromise is going to be, and it's more likely to need more aggressive treatment via a surgical intervention of some sort. But here's the deal about these rotator cuff strains and tears. 60 years old or more with no shoulder pain, 54% of those people have a rotator cuff tear. Again, no shoulder pain whatsoever. Rotator cuff tears are common. 34% of those under age 60, again, with no shoulder pain, have evidence of rotator cuff tear. And studies show that PT is as effective as surgery, in many cases more effective if you are good at working with someone that helps you move well, have that shoulder move well. The bottom line is this: many diagnostic tests will give you an unfair representation of what's really happening in there. There's lots of surgery, or lots of testing that's been done on high-level function people. For example, baseball pitchers oftentimes have funny findings. Most of them don't have pain at all. So there was even a study done where half the people had some surgical intervention done to the shoulder. The other half had a scope introduced, but no surgery done. And when you looked at outcomes 6 months later, there was no difference between those that had the real surgery and those that had the sham surgery. Again, looking at the source of the problem. What's the mechanical movement issue? Can we fix that? In many cases, that doesn't require medications, injections, and surgeries. And in every case, medications, injections, and surgeries do not get to the root of the problem. This is not just true with shoulder issues. This is true with abnormalities seen on diagnostic testing among people that don't have any pain at all. At the neck and at the hip and at the back and at the knee and at the ankle. It's all over the place. This is again to say that arthritic changes are as normal as wrinkles on the skin. They're going to happen. Okay. Pathology, the evidence of pathology on a test is not a predictor of pain. They're completely separate things. All right. So what are the causes of shoulder pain? So we're going to talk about 3 causes here, and I'm giving it to you right now: shoulder blades, hips, mid to upper back, all relatively close neighbors to your shoulder, especially the shoulder blade and the mid to upper back. But before we go there, I want you to understand this. I said earlier that every body part is designed to move 3-dimensionally. And we need this balance between mobility and stability. In our clinic, at least I talk a lot about Goldilocks. I like the Goldilocks story. Goldilocks taught us that not too hot, not too cold, but just right is what she wanted. Not too firm, not too soft, just right. So if you have a joint that is way too stiff and doesn't move enough, that's problematic. Likewise, if you have a joint that's way too mobile and lacks stability, that's a problem too. We don't want either of those polar opposites. We want this combination of mobility and stability, most stability. And we want all those moving parts that make up the dynamic system that leads to what seems really easy when you don't have pain, an act of elevating the shoulder to seem easy because every part's doing its job particularly well. And so when we look at these close neighbors, the common culprits of shoulder pain, we need to find out, are the shoulders doing what they're supposed to do? They have a balance of mobility and stability. What happens if the shoulder blade's too stable or too mobile? What happens if the hips are too stable or too mobile? And likewise, what happens if the thoracic spine is too stable or too mobile? Okay. The shoulder blade, as I told you before, 21 muscles attached to it. It's a floating bone that floats on the rib cage. It's connected to parts only through muscles. There's no direct bone-to-bone connection of your shoulder blade to your rib cage or your thoracic spine. There's muscular connections there. Those muscles pull at all different angles, and they're responsible for making your shoulder blade dance with your upper arm. It needs to be a concert of motion. So with your arm at your side, let's call that 0 degrees of elevation. You take it all the way overhead, that's 180 degrees. It's half of a complete circle, right? So of those 180 degrees, about 60 degrees occurs because your shoulder blade rotates upward. And the remaining 120 degrees happens because the upper arm bone moves on the shoulder blade itself. You can see that there. There's the 60 degrees of the shoulder blade in that bottom right, 120 degrees of the humerus moving on the shoulder blade, which gives us the full arc of 180 degrees. So what happens if the shoulder blade isn't doing that well? Most often, the shoulder blade gets stuck. It gets stiff. It doesn't move. And that's problematic because if your shoulder stops moving and your arm keeps moving, that's when you get the impingement. And that impingement starts with a little arthritic irritation, can lead to impingement signs, and eventually over time can develop into a cumulative rotator cuff tear strain and ultimately a more significant tear in that area. So I'm going to show you this. This is a dynamic movement of just the skeleton, and it will show you what happens in this dynamic interplay with appropriate motion happening at both the shoulder blade and the upper arm. And you'll see how if they dance together well, if they each do their movement correctly, that space between the two is maintained, okay? But if the shoulder blade stops, that space is not maintained and mechanical pressure creates issues. So let's do this. Watch this. I think the first one, I can't remember what the first one is here. It takes about a minute to go through this. I think this is going to be abduction. So arm raising at your side. This is like a snow angel, right? See how much upward rotation is at that shoulder blade? And even at the highest lift, there's still a gap there between the head of the humerus and that shoulder blade. Okay. Now I think we're going to go up in front, and you're going to see a unique movement of the shoulder blade. I think the person only raises their arm to about shoulder height in what we call forward flexion. Here it comes. See how that shoulder blade starts to work away from the thoracic spine. Now, if you were to go higher for that 90-degree mark, eventually that starts to rotate upward there as well. Okay. There you go. Now, the last one is this person's going to kind of reach behind their back like they're getting the billfold out of their pocket. Now the shoulder blade slides to the thoracic spine and almost overlaps that thoracic spine. Can you see how much dynamic movement needs to happen at the shoulder blade? Eliminate pressure in that subacromial space. It's really important. Come on now. All right, finally got it to go there. So the bottom line is that the shoulder blade doesn't move in concert with that upper arm bone. Reduced space in that subacromial region leads to compressive forces that ultimately, with enough repetition, leads to a gradual breakdown, and the frequency, intensity, and duration of the symptoms gets worse. So doing work to make sure the shoulder blade muscles move and are not too tight. And it's also impacted by what's happening at the thoracic spine, which we'll talk about in a little bit. But let's talk about the second culprit first, hip mobility or hip strength, right? So how in the world are your hips connected to your shoulders? Well, you can see all these fascial bands. On the front side, your right hip has a diagonal band that goes to your left side, your left hip to the right upper body in that area. Many more so on the back side. You can see how the left hip is connected to your right shoulder and the right hip is connected to. There's this diagonal banding that occurs in the human body. Imagine, if you would, the game of baseball. I'm a huge baseball fan. Let's imagine there's a ball hitting the gap in the outfield, and the outfielders run. One of them gets there, but there's a new rule in baseball that you can't throw on your feet. You got to throw from your bottom. How much force is a person going to be able to get if they can't generate force through the leg, through the hip, and up through the trunk? You can't throw it very far, right? The hips provide about 50% of the help when you explode and make motions with your shoulder. Okay, so any limitation of hip mobility in any one of the 6 directions that the hip moves can have an influence on the shoulder, and most likely the opposite shoulder, usually right hip for left shoulder, left hip for right shoulder. Okay, so in hip hypermobility, too much mobility can be a problem as well. In the thoracic spine, however, your mid-back is very rarely overly mobile. The mid-back is almost always too tight. And if the rib cage is the track upon which the shoulder blade moves, when the rib cage gets locked down and can't move very well, pretty soon the shoulder blade will get locked down along with it, unless you're working on mobilizing the rib cage, particularly in rotation. Okay. But all 3-dimensional movements are important at the thoracic spine as well. But if you don't move the torso well, the reaction, the functional reaction that leads to the next movement in the series or dynamic series of kinetic chain movements is going to be minimized. And that's going to have a negative impact on eventually the shoulder blade and the upper arm, which is the shoulder proper. So kind of to put it in a nutshell, if you've had shoulder issues and you've sought help, and the person that you've worked with has not looked at how your shoulder operates in relation to the closest neighbors, in particular the shoulder blade, the hips, and your thoracic spine, mid to upper back. You probably have not gotten to the root of your problem. And when those tissues are not moving well, there's going to be an enhanced likelihood that there's mechanical stress. And with mechanical stress acting upon that tissue, that friction leads to inflammation, which leads to pain. And the natural reaction is, well, let's get rid of the inflammation because that'll make me feel better. And it does. But the question behind the question is, why does that inflammation exist in the first place? It's because of friction. Why does that friction exist? It's because of poor movement habits. What can we do to fix those movement habits? That will take care of the down the line symptom related problems. So it won't be surprising for you to hear me say that if you want to eliminate your shoulder pain, you have to get to the root cause. Unfortunately, the most common treatments are not necessarily the most effective treatments. Medications, injections, and surgery, they don't get to the root of the problem. They simply mask the problem. And just because they're common doesn't mean they're effective. My encouragement is to stop ignoring or altering the pain and get to the root cause. And that requires individualized approach. We need to learn how your specific body parts move. How does your thoracic spine do its job? If it can't do its job, what impact does that have on its closest neighbors? What about your hips? Do you have too much mobility or not enough mobility? How is that impacting the movement chain? What about the thoracic spine? If you can't rotate well through the thoracic spine, how are we going to turn that movement into efficient movement down the kinetic chain? Your individual deficits need to be identified and solved. And that requires a whole body approach, right? We can't just fix the shoulder by treating the shoulder. We fix the shoulder by treating the movement system, the entire kinetic chain, a process that is both educational and empowering. What I mean by that is what you do at the start needs to change because your body will overcome one deficit and then you got to lay that next foundation. It's a process, but over time you start to feel the process empowering you to move better, giving you more confidence. We are allowed to treat multiple people simultaneously, but I don't recommend it because it's hard to get you to do the right thing you need at the right time to get the right result if I'm not in a one-on-one environment with you. And we can use our hands. I'm okay with doing those things, particularly helping the body to feel how it needs to move, or a particular body part to feel how it needs to move with everything that's happening around it too. And so we'll help facilitate movement of the arm with the shoulder blade with the thoracic spine, combining the movement with that exercise. So remember we talked about acute trauma and over time it feels better, or cumulative trauma where it's gradually worsening and gets above the symptom threshold. And if you don't get rid of the mechanical stress, it gets worse. Frequency, intensity, and duration of the symptoms gets worse. What we're trying to do by getting the stress off the tissue, by working on the entire system, is to minimize that symptomatic response so you can remain below the symptom threshold. You're getting to the root of the problem to reduce the symptomatic response. So you've heard a ton tonight, right? I wish I could tell you that we solved all the world's problems tonight, but we didn't. There are still 3 problems that I can think of. First of all, it's impossible for you to retain all this information. Your memories are limited, so are mine. And secondly, and this is probably even a bigger problem, you know what the common culprits are in all people, but you don't know what your culprit or what your culprits are, right? You might have more than one culprit. Okay, so and the third thing is, we like to say that knowledge is power. That sounds good, but ultimately knowledge does us no good unless we can do something about it. Only knowledge that we can implement is effective and beneficial. So here's what I want to tell you. You've given me your time already tonight, and I'm greatly thankful for that, right? But what I want to offer to you for giving me your time is that next step so you can individualize this in your life. We want to give you a natural shoulder pain relief consultation, which is very simply this: spend 20 minutes with one of our shoulder experts. They'll ask questions, they'll listen to your history, and they'll do a few simple tests. And you already know what they're going to do. They're going to look at how your shoulder blade's working. They're going to look at how your thoracic spine works. They're going to look at how your hip works. They're going to look at how all these things work together. And you will understand really quickly, most likely, what type of shoulder pain you have, what are the root problems that are bringing that on, and then they'll walk through with you, what does it take to make this go away? What does that process look like? And I think ultimately, even in that 20 minutes, you'll get confidence, some direction, and hope. Okay. And there are lots of benefits to that. We want you to understand how to stop wasting your time and money. We want to give you the ability to take control of your own health. We want you to do things that get to the root of the problem, avoiding injections, medications, and surgeries, and using more natural approaches so you can avoid the high risk procedures, and ultimately so you can feel better, function better, depend upon yourself, and feel like your old self again. Give you the unique solutions to your unique problems. Now, there's a value to this. Typically, that amount of time would be about $150 in the open market, countrywide anyway. Here's the benefit to you. It is no cost at all to you. If you sign up tonight or raise your hand tonight, I should say, we will get you set up for 20 to 30 minutes with one of our shoulder experts so that they can go through that process. Now, we like to give guarantees. I can't give a money back guarantee because I'm not taking any of your money. But I would say this, since it's $150 in value, if you go through this process and say, well, that was a waste of my time, just tell us, and we will, at your discretion, give your favorite charity $150. That's our guarantee. Now, I feel pretty good about giving this guarantee because we've never had to take anyone up on it because it is valuable. You're going to know what's going on. You're going to know the pain type and the primary culprits, and you'll start to understand what an implementation plan would look like. And at the very least, you'll have a little summary that you can take with you after that consultation. So that is it. And you know, I've been around for 26 years. When I was a young therapist, I would be a little bit more direct in encouraging people to do these things. I've been around long enough. I've seen way too many people deal with unnecessary pain. I've seen way too many people spend way too much money on the thing that doesn't solve the problem. The thing they're most likely to lose is their wealth. And I don't want you to go through that. I want you to get to the root of this problem. So I'm telling you, if you had enough of an issue that you wanted to hear about it tonight, I strongly encourage you to take us up on this free offer. Here's all you need to do. Click on that chat box and say, I'm in, okay? So here's the deal. I don't know where you live. You can tell us. We have 8 clinics. And so if you say, I'm in, I'd love to have one of those free screens and spend some time with the shoulder expert, you have to tell us where you want to do it. So here's your options. We have clinics in Ames and Des Moines, Newton and Colfax, Pella, Oskaloosa, Albia, and Centerville. So if one of those is closest to you, that's a great way to do it in person. You might not live close to one of those clinic locations. So if you want to do a virtual version of this, we can do it that way too. I know you got the technology to do it because you are signed up right now to listen to me. I've got a chat coming in. So there we go. Okay, Diana, we will have our care coordinator in Pella contact you and get you in. Karen, we can do the same. Just let us know, Karen, where you would like to be, and we'll get you called to set this up. I promise you, though, that I'm going to answer any of your questions. Let's see. Karen and Waukee. So are you okay going to our Des Moines office? Des Moines, it would be, it's right on the border of Des Moines and West Des Moines. I'm thinking that would probably be a good spot for you to start to do that. Diana, Pella, Newton, or Oski, you're open to anything. Okay, I'll let them know. We'll find the one that works best for you with that. Okay, very good, Karen. Anyone else that wants to sign up, just let me know. I did promise that I would answer your questions. So if you left any that I didn't get to, I didn't see any chats, but I might have missed them. I'll get to them. This is my contact information. What I want at the very least is that you see me as your musculoskeletal resource. So maybe it's not your shoulder, maybe it's your hip or your knee, maybe it's your uncle or your nephew or your grandchild, whatever. If you have a question, just reach out to me. This cell phone, this is right here. It comes right to this number. You can call, you can text. This is my direct email too, that gets right into my inbox. You can actually reply to any of the emails that we sent you after you registered too. Those don't get directly to me, but our marketing team will get that to me too. So that's an easy way to get a hold of me as well. And as you may have heard, if you were here early enough, I think later tonight, you're going to get an email from us. If not tonight, tomorrow morning. Okay, Steve, there we go. Colette and Ames. All right, Colette. we'll reach out on that. If you want to leave us a phone number, I'm hoping that Steve, if you let when you signed up, or Colette when you signed up, if you did have your phone number on there, then you don't have to put your phone number on it again. We'll have it on your registration. But you're going to get an email eventually, either tonight or tomorrow morning, as I was saying. On that email, there'll be a sign up for a free screen. If you already said that you want it tonight, you don't have to do that. If you didn't tonight and you decide you want to do it later, you can check on that. That's an option as well. But it's easiest to do it tonight if possible. You're going to get a link for this video, so you can watch that again. So that's great. And like I said, you can reply to that email at any point in time to communicate. All right, Colette, we will call you for a free screen in Ames. So that's great. I'm assuming you have the same last name as Stephen. Hope so. There you go. Wonderful. All right, folks, I appreciate it went a little bit longer than expected, but you were a great group. Again, if you have any questions at any point in time, please reach out. I'm happy to be a resource for you to answer any questions, to get you in the right direction with this. We hope that we found that this is beneficial for you, and hope we can help you find a solution to your problem that's not just masking the problems, but gets to the root of the problem. Blessings to you all. Have a great night. Take care.